What's up, guys? So another quick video. Amy and I had a patient the other week in atrial flutter. And I'm not gonna lie, I've kind of become unfamiliar over the last couple years of not being on the ambulance. And so I thought I'd do a quick video. So what is atrial flutter? How do we recognize it? Should we treat it? How do we treat it? So fancy definition, atrial flutter, an ectopic activity that is conducted through a fast pathway through the AV node that is causing a re-entry tachycardia. It's a pretty fancy way of saying it. I'm not gonna lie, even I need to dig into that a little bit more. I'll include some links in the comments to Life in the Fast Lane and a few other links that you can dig in a little bit more to the electrophysiology. So how do we recognize it? It's going to be that sawtooth that everybody talks about. Let me turn my camera around. So here's that 3-to-1. Sometimes you're going to have 2-to-1. You're going to have 4-to-1. Atrial flutter. We are going to look. Lead 2 is a decent lead. I like looking at V1. That is going to be right over the atria, and so yeah, it's just a better, in my opinion, a better lead to look at to diagnose. Should we treat it? Technically, at the end of the day, we should not be treating, well, maybe, a rhythm unless it is compromising cardiac output or hemodynamic stability. If it's not, send them off to cardiology. I don't really care. And there's caveats to that, obviously. How are we going to, let me pull up my note here, how to recognize it, should we treat it, how would we treat it? So if they are stable, borderline unstable, how are we going to treat it? We're going to give this wonderful calcium channel blocker called Cardizem. Cardizem comes in 25 milligrams per 5 milliliters. I don't think it comes in any other concentration. And so got my little syringe here. First of all, I talked to Dr. Berger. The dose we're going to give is 0.25 mg per kg, additional dose of 0.35 mg per kg if the initial dose does not work. And so, also quick note, this is a rate controlling drug. This is not going to convert them. If they convert to sinus rhythm, that is merely coincidence. That is association, that is not caused by this drug. So we're going to be treating a flutter when their rate's like 150, 180, 200. So this is going to bring my rhythm or bring my rate down. That's the only thing. So 0.25 mg per kg. How do we do that? So my patient's 187 pounds over 1 times 1 kilogram over 2.2 pounds. Pounds cancel out, equaling 85 kilograms. That's how much my patient weighs. 0.25 mg per kg. 85 kilograms over 1 times 0.25 milligrams over 1 kilogram. Kilograms cancel out. 21.25 milligrams is my dose that I want to give. So how do I get that? So I've got my DILT or Cardizem, same drug, 25 milligrams per 5 milliliters. 21, I'm going to desired over halves, 21.25 mgs over 25 milligrams, that's what I have, times 5 milliliters equals 4.25 milliliters. So I got my syringe, pull it up. Oh. Bam. There's your 4.25 milliliters, 21.25 milligrams. When Berger says give this over 2 minutes, this isn't that like Zofran that's like 30 seconds. Like give this, like legit give this over 2 to 3 minutes. We don't have syringe pumps, so just sit there. This can drop your pressure very quickly. This can also obviously drop your rate, which is what we're wanting. However, going to drop it, if you slammed it, it could give it very, very, very fast. Side note, a little bar trivia. What do we give to fix Cardizem overdose or over treatment? So DILT is a calcium channel blocker. We would give calcium. We're probably not necessarily going to give like atropine to get their rate up, or we might. Yeah. So if the second dose doesn't work, the 0.35 mg per kg, we're likely to, or even if it does work, we'll probably still put them on a DILT drip and then ship them off to cardiology to likely get an ablation or something like that. Yeah, that's going to be it. There'll be another video right after this on synchronized cardioverting, which is what we're going to do if the patient is hemodynamically unstable. So you got that high rate, that 150, and now you've got 62 over 38 or whatever. That's when we're going to be synchronized cardioverting. We'd like to give a little Versed, a little fentanyl to, you know, have them a little bit more comfortable. Most patients describe cardioverting as getting kicked in the chest by a horse. If your pressure is 60 over 30, well, saddle up, because I'm not taking the time to get Versed and fentanyl out of the Omnicell. So you're probably just getting cardioverted. One thing I forgot in the video, so when you hit sync on the monitor and then you charge to what likely is going to be 50 joules, will likely be your initial joule setting, and then you hit shock, to do another synchronized cardiovert, you need to hit sync again. So if you hit sync, charge, shock, it is now not synchronized. So if I charge again, I'm now defibrillating, aka stretch out and get ready to do CPR, because you're likely going to cause them to go into some lethal arrhythmia. Anyways, yeah, if y'all have any questions, leave them in the comments or let me know. Hey, so to synchronize cardiovert a patient in atrial flutter, we're going to go to likely the initial setting of 50 joules. We're going to synchronize cardiovert, not defibrillate. So what are we going to hit? Sync. And then you hit charge. And then once it charges, you shock. We are likely going to want to, if the patient's remotely stable, sedate them with probably Versed, fentanyl, something like that. However, if your pressure is 60s over 40s and you're in A flutter, I don't really care. I'm just going to tell you to prepare for the ride.